Good morning. I'm with Dr. Dan Hallam, and we're going to be speaking about breast cancer. A little bit about Dr. Dan Hallam. Dr. Hallam is a general surgeon who practices at Passavant Hospital and is a partner with Springfield Clinic. He's board certified in both general surgery and surgical critical care. Presently, Dr. Hallam serves as the medical director of the ICU at Passavant Hospital. The topic today is a very broad topic, and we're going to get right into the meat of the subject matter here. And I'm going to ask Dr. Hallam, what is the incidence of breast cancer here in the United States?
In the United States, there's greater than 200,000 cases of breast cancer diagnosed each year. Worldwide, obviously, breast cancer is the leading cause of death in females. In the United States, it's the most common female cancer in the United States. It's most common cause of cancer death in women. It's the main cause of death in women ages 40 to 59. And as I mentioned, approximately greater than 200,000 cases are diagnosed each year in the United States.
We always talk about breast cancer as being predominantly for the females, but we can't exclude the males, although the incidence of male breast cancer is very low. But what is about the statistic in the United States for male breast cancer?
Obviously, the incidence of breast cancer in men is much lower than in women. It's about almost 100 times lower, but there's approximately 2,000 cases of male breast cancer diagnosed each year.
What are the most common risk factors for breast cancer?
The major risk factors are obviously age and gender. Being the older a person gets, the higher incidence that you find of breast cancer. Additionally, obviously, breast cancer is much more common in women, as we mentioned earlier, approximately 100 times more common.
As far as what should a woman look for as far as some of the signs or symptoms of breast cancer?
Sometimes, and we'll talk more later about this, but sometimes there's no signs, and that's where screening mammograms are very important. But common signs of breast cancer is a lump that is noted in the breast or potentially in the under the arm. Abnormal changes of the skin, such as dimpling, redness of the skin, change of size or shape of the breast, inversion, which is pulling in of the nipple. These are all signs that are associated with breast cancer.
You briefly mentioned, which is a very good topic or something to discuss, is that sometimes breast cancer is caught early just through normal screening. What is the screening guidelines for early detection of breast cancer?
We advocate that women do monthly self-exams, and monthly self-exams entail visual inspection of the breast to basically look for those changes that we were talking about, any dimpling of the skin, redness of the skin, changes such as that. Additionally, second portion of that exam requires palpation of the breast such that the woman can detect any changes in the breast, any change in as far as size of a lump or a new lump. Because what's important to know is it can be very normal to have fibrous breasts and to have lumps and bumps within the breast. The reason we advocate monthly exams, it's important to know if those change. Additionally, we recommend a yearly exam by a physician as far as a breast exam, and then mammogram. There's many guidelines out there. The American Cancer Society recommends a yearly mammogram starting at the age of 40, depending on your risk factor. If a woman would have high risk factors such as family history of breast cancer or potentially carry a genetic mutation that increases the risk of breast cancer, then that age is actually lower than 40 to start initial mammograms.
I know you said monthly self-breast exams, and to note the differences, of course, I'm sure there is some differences monthly just by a woman's menstrual cycle.
Right, and so what we recommend is to do the exam approximately the same time each month because you are correct. There are changes in the breast with the menstrual cycle.
And abnormal discharge of the nipple is also something to consider.
Correct.
Once a woman finds a suspicious lump of some kind, can you talk us through what she might expect when she might call her primary care physician or OB-GYN and bring this to their attention? What can she suspect for the medical workup before they even get to your office?
Yeah, first of all, my recommendation is not panic, okay? And never, ever not take a new lump or change in the breast seriously. I would recommend seeing their primary care physician, who most likely would obtain a mammogram, potentially an ultrasound of the breast, and to visualize the lump and to look at the internal characteristics of the mass. However, having said that, sometimes mammogram and ultrasounds don't show these lumps. If you can feel the lump, we never ignore a new lump. So even if the mammogram and ultrasound may not show that, potentially a woman may need a biopsy for this.
So that's how they might get sent to your office? Or
Correct.
for
Correct. As a general surgeon, usually the patient has been seen by the primary care who's ordered studies, and if there's some abnormalities with the studies, then it's sent to us to further discuss and decide whether a biopsy is warranted or not.
Well, definitely, I'm sure you want to make the listeners realize that you don't want to disregard any of those.
Yeah, never, ever disregard a change in the breast. And like I said at the beginning, don't panic. Most of these are benign, meaning they're not cancer.
Good
so
point.
most changes in the breast are not cancer. But we want to make sure that it's not. And the key is you want to catch, if it is, you want to catch this early, and that's much more treatable at that stage.
I know you briefly mentioned a mammogram and ultrasound. There's other diagnostic studies like MRI. Can
Sure.
you expound a little bit between those differences? What's better, what's worse? Not worse, I should say. What's indicated in each individual case, so to speak?
Mammogram is an X-ray of the breast, and the breast is compressed, and there's X-rays taken of different angles of the breast to visualize if there's changes in the breast as far as distortion of the breast tissue, if there's visible mass, if there's what we call calcifications within the breast. These are areas that sometimes you can't feel a lump or bump, but they give specific characteristics on the X-ray. Ultrasound is another modality that's used. This is not an X-ray. This uses sound waves, and ultrasound is not a good screening tool. It's basically used to evaluate a known mass or lump or lesion that usually you can feel. It's very good at looking at the characteristics of that lesion in a localized area, but not the entire breast. MRI is also a very good tool for imaging the breast. MRI has limitations mainly because of its sensitivity. MRI is so sensitive that any little, not even abnormality, any little lesion, small speck is picked up on the MRI, and because of that, it's not a good screening tool. In fact, if you used MRI as a screening tool, we would be doing a lot of unnecessary workup of breast lesions. MRI is a very good tool in patients with a known cancer to rule out any other suspicious lesions within the breast. It's also an extremely good tool in screening purposes for patients who are at extreme high risk for breast cancer, giving a potential genetic mutation or a syndrome in which the patient would be at an extreme high risk for breast cancer.
Isn't it not true, though, that in some cases you might use more than one modality for the diagnosis? Like a woman could have a mammogram and an ultrasound?
Correct. And usually that's the case. Most of the time, the screening tool we use, as mentioned before, is a mammogram. If there's an abnormality found on the mammogram, then usually an ultrasound follows this up to look at that area of abnormality and to kind of guide us to get more information about the abnormality, to guide us in decision making as far as whether we obtain a tissue diagnosis or not.
once the lesion is considered suspicious, how do you as a general surgeon decide whether you need to do a needle aspiration or a lumpectomy or a mastectomy? I'm sure there's a lot of different ways you can go with this, correct?
Correct. So, first of all, it depends on the lesion itself. If I see a patient in the clinic that's referred to me for evaluation of an abnormal lesion in the breast, and the lesion is palpable, meaning that on exam we can feel the lesion, then it's appropriate to do a needle biopsy of that lesion within the office. We can get the results fairly quickly that way. It is an invasive procedure in the sense that requires a procedure, but it doesn't require you to go to the operating room and doesn't require a large incision. Additionally, a needle biopsy can be obtained even if there is non-palpable or lesion that you can't feel within the breast. And a lot of times we'll send these patients back to radiology where they have an image-guided biopsy, whether they use mammogram or ultrasound, to visualize the suspicious lesion and then obtain a tissue diagnosis with a needle biopsy. There are times that we do take patients to the operating room for tissue diagnosis, and that's called an open excisional biopsy or a lumpectomy. The problem with this modality is if it is a cancer, at this point we're trying to make a diagnosis and we're not treating a cancer. So if the diagnosis would show a cancer, then that patient would have to go back to the operating room for further surgery. A mastectomy tends to be reserved for patients that have had most of the time have had a diagnosis of a cancer, and that kind of brings us to treatment. And the mainstay of treatment for a localized breast cancer, meaning cancer that has not spread outside of the breast or the lymph nodes, is surgery. And the two main surgeries are what we call breast conservation therapy, where the entire breast is not removed, just the area surrounding the cancer or tumor is removed, versus a mastectomy. A mastectomy is where the entire breast is removed. Most cases, a breast conservative therapy can be, or a lumpectomy can be used. What's interesting is if you look at the data of mastectomy versus breast conservative therapy or lumpectomy, the outcomes are really not different in most cases, unless it's a large tumor. If a patient has a small breast versus a large tumor, then potentially breast conservative therapy is not warranted, as you would have a poor cosmetic outcome from this. But also available to us, even if we do a mastectomy, breast reconstructive surgery with a plastic surgeon can be performed as well. One thing that we do when we perform our surgeries for breast cancer, we always evaluate the axilla, which is the armpit area. We have lymph nodes in our armpit. We want to make sure that to document if those are involved, because that guides our therapy as far as chemotherapy and potentially radiation therapy.
I know there's a lot more to discuss, and I mean we can even get into the treatment, but that actually we can reserve for another broadcast, because the treatment of cancer of the breast is very extensive, whether it's radiation, chemotherapy.
Correct.
And of course there's the differences of the the stage of cancer. But overall, if you can tell the listeners, the prognosis for cancer has improved within the last few years.
Yeah, over the last decade, mortality's decreased by approximately 20%, and I think the biggest reason for this is increased screening, and cancers are caught at an earlier stage. Obviously, treatment of a stage 1 cancer versus a stage 4 cancer, which we won't get into all the details of the staging, but the lower stage of cancer is much more treatable. Prognosis is significantly improved. Mortality, for example, for a stage 1 cancer with good surgical margins and treatment follow-up is extremely low.
And that's what we need our listeners to understand, that because of good screening, because of early detection, we can have way better outcomes and survival rates, correct?
Correct. Yeah.
Well, thank you very much, Dr. Hallam. Do you have any other tidbit of information or pearl you'd like to give our listeners before we close?
Well, the main thing is, and we touched on this earlier, is to not ignore any changes. If you have questions, even if you're not sure that there's a change or not, don't hesitate to ask your doctor, because as we mentioned, if cancers are found earlier, they're much more treatable, and so the key is to not ignore any change at all within the breast.
Well, thank you, and that's very good advice from Dr. Dan Hallam. Our next broadcast will be with Carrie Carls, who is the nursing director of Passavant Hospital. She's in our continence program, and we are going to be talking about the subject of incontinence. I also encourage our listeners, if you have any suggestions on future topics, to email us at medicalminutes@passavanthospital.com. Thanks for listening, and good health.